The broadcast is now starting. All attendees are in listen-only mode.
Well, friends, welcome to the next AHP series of webinars. And today we have with us Professor Dr. Henal Shah from Department of Psychiatry at Mumbai. And she is the co-director of the GSMC Female Research Institute. And also she has done the MHP from Maastricht and very, very active in most of our medical education programs. She'll be speaking on early clinical exposure. Over to you, Henal.
Thanks. Good evening and welcome all of you to this webinar on early clinical exposure. And media is such a lovely thing. I can sit here and talk to all of you all across India, and it feels wonderful to do that without getting my toe out in the weather, which is raining right here outside my house. I must thank Dr. Sanjay Bedi and all the people from AHP, Dr. Regi and team who have invited me here to talk about early clinical exposure. I think we really started discussing this topic when the vision statement came for us from MCI. And I remember going for meetings at MCI where we were talking about how to implement early clinical exposure. And I think around that or just before that, we had made a presentation on early clinical exposure at the network conference in Canada, and that was Rashmi and myself. And therefore, I must acknowledge Rashmi Vyas, the Assistant Vice President of FAMA Philadelphia Education, who, together with whom I have presented this, and a lot of these slides are part of that presentation, and of course to FAMA, which has given us this platform to learn all these things. So with that, I know that many people are really doing some amount of early clinical exposure. I wonder how many of you all are doing it. So those who are, can they indicate on the poll? Is it possible, Dr. Bedi, for them to use that poll and indicate how many of them are doing it? Well, I'm not sure, but I know that I've seen a lot of papers coming from India which talks of early clinical.
Please raise your hands. Dr. PC Gilwaz from Kerala, he wants to, he has raised his hands, yes.
Yes, please.
Dr. Gilwaz,
tell us about it.
Dr. Gilwaz, please unmute yourself. Dr. Gilwaz, I think, yes, Dr. Rajkumari Devi. Yes. Please unmute yourself. Dr. Rajkumari?
Hello?
Yes.
Good evening. We
Yes,
can hear you, Dr.
We can hear you, ma'am. You have muted yourself again. Please unmute yourself. Yes.
Is it okay, sir?
Yes,
Okay.
yes.
So from this year, we are going to implement this early clinical exposure. We just finished our foundation course today. So for 100 students, how will we take them to the clinical world, or I mean, what is the best method of teaching to bring them to expose the students to early clinical exposure, ma'am?
Thank you, Dr. Rajkumari, and I hope I can answer that question by the end of my webinar. So hopefully that is something that you're going to learn and realize at the end of this. So, well,
okay.
What I do realize is, thank you for your question. I do realize that a few people may have tried early clinical exposure, and many are not sure how to really do this. And therefore, let's just think about it. I mean, we have this foundation course, and we know that the new curriculum is being implemented, and it's basically a roadmap to overcome shortcomings. And one of the major shortcomings that is there is the lack of relevance and context to our preclinical studies, and which in turn then causes low motivation and poor application. So this is what really has prompted early clinical exposure. If we think of Flexner, Flexner is his report of 9010 is a big report because it changed a lot of medical education around the world. And when he spoke in his report, he said there should be 2 years of basic training followed by 2 years of apprenticeship. But somewhere along the way, it so happened that in our traditional teaching, we had pre and paraclinical followed by clinical. And it was really like a divide between the two. So preclinical was isolated. There was no context or understanding as to what was happening. I know in my days when I was a student and when I learned Krebs cycle or when I learned most of my biochemistry, I could not relate to how it was being used. Anatomy yet made sense because I could look at my body and make sense of it. But I could not understand biochemistry at all. So in that sense, because of this divide that was there was a big problem. And so to break this divide came the idea or the concept of early clinical exposure. And this is not something that we are talking about. It's been going on for the last maybe 2 decades or more all over the world. And people have worked in exposing people to the rural community, exposing students to geriatrics, palliative care, radiology, nursing, dentistry. So it's happening in many health professionals' education that this is coming up. So what does it mean? What do you mean by early? When is it early? Early means that you're teaching it traditionally in the preclinical phase. So usually in the first year and maybe the second year. So either early clinical experience or exposure. So when you say an experience, what do you actually mean? You mean that there would be an authentic human contact. Where would it be? Either in a social or a clinical context. And what would it do? It would enhance learning of health, of illness or disease, and the role of the health professional, doctor, nurse, dentist, whatever it is. And this is what early clinical exposure is. So what is it? It is a teaching learning methodology to promote exposure with some aims. So basically it is one form of teaching which can help us in many ways. So what is the aim of this? Of course, when they are exposed to clinical work, they may get some knowledge. We don't expect them to have the same knowledge, say a third MBBS student would have when he goes to the wards. So the amount of knowledge that they have in terms of anatomy, medicine, physiology may be different, but they may gain other knowledge, how patients are supposed to be spoken to. They will learn some skills, clinical skills, examination skills, but more important, communication skills. They will learn professionalism. They will learn the right attitudes. They will learn how to talk to a patient, how to behave with a patient, and most important, they will feel like a doctor. And this will facilitate the transition from being an undergrad science student now becoming a doctor. So that feel of a doctor, when you enter the ward or you see patients would come. And most importantly, it will bring some context and relevance to what you're studying. What does that mean? That if I am studying a nerve cell, what does it actually mean when I go to the wall? When I am studying waves in the brain, what does it mean? If I am studying about the nerves, what does it actually mean in clinical practice, and why should I know it? I think that is where it is being answered. Great, that is the aim, but is it really happening? Well, many people who have used it have got replies both from students, faculty, institutes, and most students feel that it really helps them to get motivated. they love the way when they see physicians interact with the doctor, because it gives them some idea what the future holds for them and gives them a thinking about how they should prepare for the future, how they have to interact with students, people, teachers, and it generates a lot of interest. And most important, like I said, you feel like a doctor. So that's very important for anybody who has logged so hard to enter medicine. Great, so that's what students feel. What about faculty? Let's hear it. Is there anybody who has actually used early clinical exposure? And if they have, can they raise their hand so we can ask them about what their experiences were as faculty in using early clinical exposure?
Dr. Deepthi Shastri.
Hello, ma'am. Good evening.
Good evening.
I'm an anatomist, and the kind of early clinical exposure we have given to first MBBS students is we actually would not take them to the hospital and make them examine the patients, but we would give them problem-solving exercises at the end of each region. For example, after they finish upper limb, we used to give all the cases which are generally seen in practice, which are an Indian medical graduate should have been able to diagnose, like very low upper limb fractures of limb bones or dislocation of joints and so on. We give these cases and then ask them the anatomical basis of the same. So actually when we give the case, we give a case scenario where they need to even be able to communicate to us. How we make them communicate is by expressing the anatomical basis of that clinical condition to the rest of the class. So that way we would check their communication skills, but we actually didn't make them communicate with the patient and take them to the wards earlier.
Even then, how did you find it? How useful, Dipti, if I may ask you, Dr. Dipti, how useful did you find it?
Of course, they found the relevance of basic science to clinical sciences when we did the problem-based learning. But of course, that part, as you mentioned, professionalism or attitude and communication skills that a doctor needs to, kind of express with the patient, that is something that we did not expose them to. And we intend to do it this year.
Fantastic. So, thank you for sharing, Dr. Dipti. And as Dr. Dipti has said, it kind of increased the excitement to learn, and it made it simple for them, more simpler for them to integrate basic science and clinical medicines. And I'm sure the comprehension of basic science therefore improved. So even the teachers feel that, even the students feel that.
Dr. Aarti Kinkar.
Oh, sure.
Dr. Aarti, can you unmute yourself?
Yeah. Good evening, madam.
Good evening.
Yeah, one of the ways in which we tried doing it about 3 to 4 years ago is taking this first year students to the camps. We have health camps. So where they used to sit with us, with the clinicians, and they used to watch us and see how we interact. Say a child had come with, say, a lump in the neck. So then once the patient, we finished everything, we used to just have a 5-minute thing with the students, about 3 to 4, that what is this lump over here? So they will say lymph node and like this, but it used to be just brief things. And then they used to go back and explain it to the other students. We tried it, and they just loved it because they almost felt like they have already become a doctor. So, yeah, we camps and making them sit with us, and after every patient, just briefly tell them about it.
Excellent.
Dr. Sarna.
Good evening, madam. Hello.
Yes, Dr. Swarna, we can hear you.
Ma'am, good evening, madam. I'm an anatomist. Actually, in our institution, when we are taking anatomy classes, I used to start with some clinical condition, like videos or photographs, something like that. And I used to start with some questions, which is more relevant to the anatomy of the topic. And at the end of the class or session, I will go back and I'll ask the questions what I posted in the initial. So then they will be. Hello.
Yeah, I'm listening to you. So you ask
yes.
the questions, yes, and?
Yes, ma'am. And sometimes we used to bring patients to the classroom, and we will discuss on that so that they can see the patient actually. But we won't send them to the clinic so far.
All right, excellent. So
Dr.
we seem to be having.
Dr. Satendra has raised his hand.
Yeah, sure.
Yeah, good evening, everyone. I would like to share our experience of early clinical exposure. We developed and validated virtual patient to impart early clinical exposure in endocrine physiology. So we basically, from thyroid physiology and diabetes, we created 2 virtual patients. So initially they began with the chief complaint of unintentional weight gain and polyuria. And we piloted it, and after that we implemented on the first-year medical students. They could go online from anywhere, be it on their mobile, on their tablet, in the library, and they can actually go through the whole process of clinical reasoning. The virtual patient can answer to every question which they can type or in the chat box, and he will respond to those particular questions. And based on that, they can go in any direction. They can make a faulty differential diagnosis as well. They can order wrong lab investigations as well and propose a wrong management. But after that, there was an inbuilt feedback so that they know where they are going wrong. I think this is a very good thing for a country like India, where there is a huge, medical, the strength of the students is very high, and not everybody can go and see typical cases. So this is one way where they can safely practice early clinical exposure. And the study has been published in Advances in Physiology Education. So faculty member can read the whole paper over there. And the second one was we had the disability competencies, in which we had a panel discussion, which I called Medicine's Great Teachers. And in that, I brought a wheelchair user having multiple sclerosis, a deafblind person, and again, a person having osteogenesis imperfecta. Now, these are the things which we teach medical students, but they had never ever exposure to these conditions. They don't have any lived experiences. So listening to these patients as teachers, they clarified their concepts very well, and probably when we will be teaching them in physiology about multiple sclerosis, they will not look at multiple sclerosis just as a syndrome or a number. Rather, they will probably think about this panel discussion and the gentleman who shared his own personalized story, and they will become more humanized because of it.
Excellent. That was fantastic. Thank you, Satendra, for sharing that. Both the use of technology and actual experiences of patients can have such an impact at different ways. So thank you, Satendra, for sharing. That's really useful. So if we really look at it, we can really use ECE in 3 different ways. One is as a classroom setting, one is in the hospital setting, and the third is in the community setting. And the fourth, the virtual setting, which can be used in any of these places. So when we think of classroom setting, we can think about patient actually brought to the classroom, or case discussions, or other ways which we will talk about now. If you think of hospital settings, you can think of going either to the hospital or the primary care exposure, and a few more which we will discuss, or community settings. The idea is that when you do all of this, there'll be training in basic clinical skills, there'll be demonstration of clinical problems, they will gain some knowledge, but heaps of attitudes. There will be exposure to ethics and professionalism. There can be discussions and ideas about that. There will be communication skills which will improve, and there will be some sensitization about humanities. And it will bring context to what we're teaching. get some social relevance, and this will have to be done deliberately. Just taking them there is not going to happen. So how exactly are we going to get that social relevance, teamwork, and context is what we will discuss for the next few half an hour or so that we'll be discussing. So as Satendra said, one, we got a virtual patient in the room. That's because it's not always possible to get a patient to the classroom. I know that Dr. Swarna Devi said that they tried getting a patient, but patients may not be available, may not be in a condition to come, and it may not be the right timing. So there could be so many things which would not allow a patient to come in. So one of my most memorable lectures in psychiatry were when one of our senior doctors got patients in the classroom and demonstrated signs and symptoms. And I can yet vividly recall that whole class. It made such a deep impression. But that is not always possible, and therefore comes the value of either virtual patients, getting photographs, videos, and getting paper cases. As I think Dr. Dipti was talking about that they use cases in their things where they did kind of a problem-based approach and a sequential exposure of cases. But remember that besides cases, we can get other things like photographs, X-rays, laboratory reports, cardiograms, and I think that was mentioned by Dr. Swarna Devi also, who said that you would bring a clinical relevance to that and then start the rest of her teaching. The importance of all of this is that why cases? Why do we want cases? Cases provide a focus for learning in many ways. Even in traditional teaching, when we're doing lectures, we put in a bit of cases to give some relevance. It can become a framework for discussion. So a person recalls what they already know, and the group can, or the individual can very quickly decide what they know, what they don't know based on the case, and therefore then what are the learning gaps and what should be the next learning objectives. So the framework then for the learning is the case. A well-constructed case is like a surrogate teacher. It never replaces the teacher, but it's useful. And a well-constructed case will, come bit by bit in a sequential manner. As the student thinks further, more information is given to make them think more critically and analytically. Remember, a case is not a textbook. So it has to be short, crisp to generate the right amount of thinking and analysis. So it's most important that the case matches the goals, objectives of the curriculum. And remember, we are also trying to get social relevance into the picture, attitude, values, ethics. Therefore, these kind of things need to come into the picture. I'd like you to read this case. This is a 7-year-old girl who's daydreaming and poor in studies, can't read properly, maths is not also good, and maybe she's not really a troublesome child, but not doing well in academics. And, if this case is given, what are the things you can discuss? What do you think you can discuss on this case? For a first-year MBBS students, what could you discuss?
Dr. Deepti, can you comment?
Well, we do have students who do behave this way, but I guess a small group teaching would help in such a case. Ma'am, what exactly do you want to discuss? The case per se?
No, I am saying if this is the case, this is a case discussion which you've taken to discuss early clinical exposure. This is the case you're telling your students. From this, what teaching learning objectives could you have?
Okay, so they need to identify the objectives. They have to lay down the objectives for working on this case. Or you want what setting we have to teach?
What would be your objective to give this case?
Okay, it could be a small group discussion that the students can do and then come up with their own. Yeah.
What do you think they should discuss?
about the attitude of the child and the learning problems that the child is having in school.
Excellent.
And also that the child is not hyperactive. So all cases are not but like generally if the students are daydreaming or poor in studies, we tend to label them as hyperactive attention deficit. So we should not directly go to a diagnosis. So they should come out with some kind of differential diagnosis for this. And the students would be of first MBBS. Is this a case given for first MBBS?
Yes, first MBBS.
All right. Okay.
So if it is first MBBS, maybe they can also talk about what is the physiology in learning and attention. What is the role of teachers and families in development? What is the neuroanatomy and physiology of of the brain in learning, attention, plasticity of the brain? When does it change? So see, there could be like between the two of us, we've thought of 20 different things. So the idea of putting that case is that when you construct a case, you have to so construct so it matches your objectives. You can't just pick up any case and say, let's discuss. Great, people will enjoy it, but they may not repeat it. Therefore, when you're planning a case, you have to think about, when you're creating a case, you have to plan the case, construct the case, format the case, and prepare the use of the case. You may do this not only with colleagues in your department, you may take help of clinical colleagues also so that the case becomes more authentic. I'm talking about paper or virtual cases. So you will have to think of first, where am I going to use it? Okay, it's in first MBBS, but which part am I going to use? Let's say I'm using it for when I'm with urinary tract. So what could my learning objectives for it be? I want to teach them anatomy and physiology of the bladder and the bladder control and the changes that happen with hormone. So then I have to think about what common clinical scenario can I use to promote these integration of all these objectives: anatomy of bladder, physiology of bladder, bladder control, hormones and its effect. So then maybe I can get a case of urinary incontinence and we can discuss all these things. Does that make sense? Yes?
Yes, ma'am. Yes, ma'am.
Yes. So then the next thing is, once you have decided what are the objectives, the next part is what content will be there to meet these objectives. So what will I have in that content? I may describe the clinical signs and symptoms of urinary incontinence in a menopausal lady. And if I give a case which has that description, this probably will lead to discussion which will talk about anatomy, physiology, and bladder control. And because it is a menopausal lady, hormones may come into the picture. So fine, I may teach anatomy, I may teach physiology, but I also want to get in social context, professionalism, values, and ethics. So what questions or what should I put in that case which will allow me to ask these, to involve these kind of objectives? Can anybody give some ideas what you would put in that case of a menopausal lady with urinary incontinence to discuss professionalism, attitude, social context, ethics?
Dr. Himangini Shah.
Yeah.
Hello. Can
Yes,
you hear
hello.
me?
Yes, very clearly.
Okay. Well, what we could do is add a bit of scenario where the patient goes to a doctor and the doctor just tells them that, oh, it's these things are common, it just happens, and not really takes up as seriously, and sends her back with not real much treatment without giving them a proper hearing or a more serious kind. Like, saying this is a chronic kind of thing that is face. So,
excellent.
Yeah, so they could go back and say, what would you comment on that? How do you think was the doctor's
Excellent.
response?
If they saw that interaction between the doctor and the patient, they could talk about A, the shame the patient feels, B, the attitude of the doctor, or you could do other things also, like what about consent while examination? What about teamwork?
Yes.
Because it would involve, many of the physiotherapists for exercises for improving bladder control. So how was the teamwork that was being done? You could talk about surgery and the economics of surgery. This poor lady can't afford surgery, so what is she going to do? So there are so many ways that adding one or two lines that we can include things like social context, professionalism, values, and ethics. So
Yes,
when
absolutely.
you're taking that case, you have to think of, besides anatomy and physiology, which you're trying to teach, integrate all of this. And then after you've thought of all of that, you also have to think, how will this other curricular elements be integrated into your case? So when will the lecture be? When will the case be? When will they be doing a visit if they're doing something? When are they going to the lab, or if they're going to the gynac ward? Whatever rest that is being planned, how all this is going to be integrated is also very important. So it's planning the case, constructing the case, formatting the case, and then also thinking about how we are going to use the case in the class. Anything that we talk about has to have assessment. So we have to think of assessment. Whether it is knowing whether their knowledge has increased, knowledge of anatomy, physiology, knowledge about dynamics and stigma attached to the disease, whether they have got some feedback and what they feel about that, whether they can use some reflection, or whether they can apply any of this information. So in always learning, when you're making a case, also think about how are you going to assess what they have learned. So like we said, you can do in the classroom with case discussions, virtual, patient brought to the class, paper cases, or even getting clinical investigations to the classroom. Then we can do hospital visits, community, improve all these skills in the time so that there is context, social relevance, and teamwork. Let's go to the next part. Okay, so I want you to observe this video. Write your observations about one or two in the chat box, and let's see, we'll discuss what are your observations. I'm just putting on this video.
Whoa! What do you see now? I can see a boat. Surprise and delight is the heartbeat of our school. It is that element of fun and excitement and engagement. It's taking anything that you normally would do and then trying to crank it up to something that's awesome. It is embedded in every aspect of our culture. Even the space itself. We have holograms. We have vending machines that are stocked with student product. We have a hallway made of lava tiles.
Surprise and delights also happen within the classroom. Oftentimes we use technology. One of those surprise and delights that I love a lot is the virtual field trip.
What do you think the scientist is studying? The penguins, maybe? He could be studying penguins. You're right.
You can change the place or the space. It can be just a treat, the activity itself.
Okay, so guys, you all remember that yesterday in class we read Donuts Don't Lie. And the author, Angela Wilkinson, is a former graduate of Eminence High School.
Today we had the opportunity to the author of the book Donuts Don't Lie questions.
After publishing it, I did wonder, like this book?
Then Miss Montgomery, she gave us donuts.
I'll go ahead and start this one down this way. It's so good.
Surprise and delight completely changes the school culture. It makes it fun, great place to be.
We want kids to want to be here. We want them to be thinking differently and to make them creative. So surprise and delight, it triggers new ideas for everybody. Another clue.
Whoa! What do you see now?
All right, so think about what are your observations, and then we'll take a few of them, and then we'll see what is that people have observed. If hands are up, Dr. Bedi, you can ask them what they have observed.
You can write in the chat box.
Yes, you can write in the chat box also.
Yes, Dr. Deepti Shastri again.
Can I speak?
Yes, please.
Create an ambience that is fun and is also conducive to learning.
So what you observed was how to create an ambience that is fun and conducive to learning. Excellent. Let's hear what others observed.
Dr. Amit Upadhyay. Amit, can you unmute yourself?
Hello. What I have observed is that they are trying to make it interesting and fun for students, and they are not. It is an interactive environment where the students are having fun, so it is not dull anymore. They have removed the dullness so that the students are attentive by themselves.
Fantastic. Thank you. Anybody else who has observed something different?
On chat, Dr. Aarti says using creative ways to learn.
Excellent.
On chat, Dr. Aarti Kinikar, she has written using creative ways to learn.
Excellent.
And
so people, yes.
Hello.
Yes, please.
Hello.
Yes, please unmuted themselves. Yeah.
Hello.
Yeah, we can hear you.
Ma'am, I can see virtuality.
You can see virtuality.
And creativity. And the students are allowed to explore the things.
Excellent.
Yes. Thank you, ma'am.
Thank you very much. So what I can understand is that people saw creativity, they saw use of virtuality or use of virtual reality. They saw that there was interest, there was excitement, there was surprise. You know, but I wanted you to actually see how space can be created to create, how space is utilized to create good learning environments. So my objective was to see if we can look at use of space to create interesting environments. And we all have talked of many things, but not of that. So the idea that I'm trying to draw, that when we usually say observe, we are not sure what we are trying to ask for or what we want. For example, let's look at another thing. Read this case and think about what you can observe if you were there. The teacher is, you're a student and your teacher is telling you about this patient and telling you, watch this consultation. What would you watch?
Anyone?
So if your teacher said,
Dr. Rohini Badre.
Yes. Hello. Yes, Rohini.
Hello.
Yes, Rohini.
Yeah. We could observe anything, whether how he's walking, the patient. I mean, how his behavior is. All things we could observe how he's behaving, how he's talking. Hello.
Right. Yes, Rohini, I can hear you clearly.
All his involuntary movements, how his movements are there, those things we would be observing, because it's not being told exactly what we have to observe.
Excellent. That's the point that I'm trying to drive home. Thank you, Rohini, for giving me that segue to get into that part. That when we say observe what I am doing, or please come and observe in the ward, or please observe something that is happening, people don't know what they're supposed to observe. And it is very important that when you're observing, we tell them who to observe, what to observe.
There is a large number of messages on chat. Vijay Lakshmi says mask face, tremors, monotonous talk. Dr. Satendra Singh says DD of tremor resting versus intentional tremor. That's it.
Excellent. And then excellent. So what Rohini was observing may be different from what Satendra was saying, was different from what Dr. Dipti was saying. So when we are looking at observation and we have some goals and learning objectives, we have to have observation which is more structured in the sense who to observe, what to observe, how to observe, and for what purpose to observe. That means we want to make this observation not a passive observation, just let things happen, but you want to have an active observation of one, what is happening, and B, analyzing as to why it is happening. And therefore, we have observation guides. Just like in learning, you have heard that you have advanced organizers so students learn better. So it is organized for them so that when they learn, it is better. So just like you have advanced organizers, when you have learning, you should have observation guides which tells them how and what to learn. For example, in this case, you could have observed the relationship between the patient and his wife and think about how a disease can impair the relationship or maybe improve the relationship between the couple. So now you've told them who to observe, what to observe, how to observe, and for what purpose. And you're going at a deeper analysis level. You could have had them to say that you see all these people and then you say that he has signs and symptoms of indicative of depression, and you can ask them to observe the relation, to observe the clinical examination for this patient. Maybe you want to see the tone, motor power, you want to see, and then you're going to tell them, after which I want you to demonstrate that. So now they have a purpose as to what they have to observe, why they have to observe, and what they're going to do about it. So whenever you're telling a case or you're getting them to observe somebody, make observation guides and make them very clear who, what, how, and why they have to observe. The idea is that there should be a target of observation. The patient, the clinician, the area they're working in, whatever it is. There should be a focus of observation. Is it the patient's condition? Is it the disability or the handicap, or the knowledge and skills, or the attitudes of the healthcare professional? So you have to have a focus, and you have to have a nature of the observation. Is the student required to make any behavioral observations and just report that? Or are they supposed to make interpretation, analysis of it, and about what they have observed? So you have to have clarity into what the observation is going to be. So not only can you tell them what to do, it is very useful to get people to work together. We keep talking of peer learning, peer sharing. So maybe students observe the same aspect and compare notes. Students observe different aspects and share ideas. Students can focus on observing communication, gathering data, interview skills. We can look at attitude between the doctor and patient, doctor-nurse relationship. You can also tell them when you're observing all of this, it is based on what the student already knows. So you're going to base on their prior knowledge. So when they are observing examination, they already know some anatomy. So it is a purpose is based on that knowledge. Not only that, you have to prepare students. Suppose you're taking them to the hospital, or if the patient is coming and they're observing, we have to prepare them on how to behave, etiquette, how to communicate. So a certain amount of effort goes in preparing the students also for observation, besides preparing observation. Eventually, we all know see one, do one, teach one is a good way to learn. So let's think of how we can use ECE in hospital setting. For example, if you're doing upper lip, you can show a patient a claw hand, and this can be a case demonstration by a plastic surgeon. You can also discuss social context in it also. Look at it, say if you're doing CNS system and you were doing hydrocephalus, you can show them a case of hydrocephalus or discuss an MRI of a hydrocephalus patient and show how changes occur and what is anatomy and how it gets distorted. Suppose you were teaching abdomen, you could think of cirrhosis, case of cirrhosis. Maybe a virtual patient of cirrhosis, a video on cirrhosis, ultrasound and finding on cirrhosis, and many of these things could help in getting. Depending on your goal, you will decide what is to be done. Like I said, they're not there just to teach anatomy and physiology, but a lot of attitude and professionalism. So how do we get that social relevance and context? Can anybody tell me what they would do, say, in a case of claw hand, if they wanted to get some of the social relevance or attitudes into that case? How do you get that social relevance and context to a case of claw hand? You could raise your hand.
Anyone? Dr. Satendra?
Dr. Aarti, can I?
Yes, of course, Dr. Aarti.
Yeah. It's like if you have a person with a claw hand, how will this person move about in the society? How will the person do the job? Are there some ways like occupational therapy that can help? Like how can they lead a good quality of life even with that deformity? So we could pose these questions and then see, or also nowadays we have some benefits like, is it a disability? Can they have some benefits in spite of having these problems? Or like say some gadgets which the person can use. So that way about the person's social life, their own sort of future, we could interact with the students on that aspect.
Excellent, Aarti, that's fantastic. So it needs a little
Dr. Pankaj Kamble. Dr. Pankaj
yes,
Kamble.
please. Yes, Dr. Pankaj.
He has lowered his hands.
Okay, problem. So as Dr. Aarti was saying, that talking about the disability or talking about his social and occupational life is one way of getting social relevance. Just as she said, whether he would get any, any surgery done. So even discussing cosmetic surgery, the role of teamwork. So whatever it is, we need to prepare and think about what we are integrate in terms of social relevance and context to this. So it is very important to spend some time in thinking what are the other questions that you're going to put into this case to bring social relevance and context. I keep grabbing this slide back because I know repetition helps in learning. So we know that from all our from all our learning psychology. So we can bring about this as we know classroom setting, hospital setting, and community.
Dr. Satendra says Aadhaar identification for claw hand.
Of course, that is a very valid point.
Satinder, I have unmuted you. You can.
Please talk.
Can you expand this point, Satinder? Okay, please continue.
Well, this is a very practical problem for people who are having claw hand, as well as those people affected by leprosy who do not have thumb impression. So it is very difficult for them to get, their finger or thumb impression, which denies them their basic right of getting an Aadhaar identification, because this is now linked with all the government social schemes. So until and unless they get this, it is very difficult. So the physician must know that this is a practical problem, and they need to understand the social relevance as well as the stigma caused because of this.
That if you give it a little thought, there are so many important socially relevant and contextual factors. I think Dr. Aarti spoke about going for health camps, and the students felt they were like doctors because they were sitting next to them and examining patients. So one is camps. Second, I know that in many institutes across the country, especially Vellore, Wardha, they're assigning families to students and they follow them up for a year, 2 years, many more, maybe for a few months. Different places have different formats. This is one way of doing it. Then there are people who do projects. They have a rural posting and they do projects. For example, they would go and check whether vaccination was done, whether there was iodine deficiency, whether there was anemia, substance use disorders in the community, how often there is depression, how often they are practicing safe sex, how often there is vision difficulties, how often, as Sitendra has pointed out in the first webinar, are there disabilities and what are the facilities available for these disabled community members. So there are many ways of involving students going into the community. And the important part, like as Dr. Aarti said, they went to the camp. But the real learning comes not only by the observation in the camps and the experiences in the camp, but after that in debriefing and reflection. Because that's what cements the learning. Unless you reflect on your experiences, you don't learn from them. It may have been a wonderful, fun thing. You felt like a doctor, but if you went beyond that and thought about what it was, why it was, how can it be better, what were my expectations, what was different, how did I see primary healthcare workers, or how there was not enough medication available, how far it is for this village person to come to a primary healthcare center. So there must be so many other things that can come up and which then become the focus of learning. And you have to give it, again, the context has to come that when they went to the camp, how do you get the basic sciences back into that? So if the patient had a lump, to be able to say anatomy, where it is, what could it be, what could the investigations be, what would you see? Not only that, you also want to see how actually systems of practice are, and therefore how the primary healthcare is there, what are the workers doing, what are their roles and definitions. You also would get an attitude for them to build up how students can be involved through activities. Of course, many people have done things like studies that if you expose them to the rural community, are they more likely to set up practice in rural community? And while the evidence for that is not out, it definitely makes them more aware, makes them more astute about all of this, and changes their attitude. One of the important things they often learn is teamwork, because in all these places, teamwork is extremely important. We come back to our circles. So we use ECE both in the classroom, hospital, community, either virtually or the real setting, to bring out so many changes that can occur. And most importantly, getting context, social relevance, and teamwork. any program, if we are planning early clinical exposure, like I heard, I think Dr. Rupali, who I'm not sure if I've got the name right, excuse me if I'm not, who talked about we're starting early clinical exposure to 100 students. But whenever you do any program, any program, the next thing that you need to do is to talk about program evaluation. You have to think of what are the outcomes as benefits to learners, teachers, your institution, region, nation, global community. So you have to think in terms of, well, as you know, this triangle, all of us must be knowing about it. So the first thing is reaction. Dr. Aarti talked of health camps and how they enjoyed it, felt like a doctor. So at the reaction level, excellent. They felt very good and they were probably satisfied with it. Or did they learn? Did they improve their knowledge, skills, and attitudes in a test setting? When Dr. Satendra was talking about a virtual patient and they could actually get their answers and feedbacks, then they could actually self-assess whether their knowledge has improved. We could give ways of testing by giving a case and discussing, giving question answers, giving reflections which will tell them whether their attitudes have changed. We actually eventually want change in behavior and practice, that is transfer of learning, and eventually we want that effects on patients and society it has, such as improves patient compliance, patient satisfaction. Unfortunately, what we will be doing is when we are doing early clinical exposure is usually as teachers of preclinical, paraclinical, we'll be seeing short-term, maximum intermediate term changes. The long-term thing is something that has to be a prospective study which will tell you how much long-term changes come. So whenever we are planning program evaluation, we have to think about how are we going to know after I've introduced early clinical exposure, whether there is a change either in their reactions and their learning, or if at all, if there is any transfer when they actually go to the wards in the third week. Now think about it. You have to create an ECE module. You have to write a clinical case which can be used as a tool for early clinical exposure. So you'll have to think how this case will be different from a case for third MBBS. So you'll have to think of all those things which we discussed about how to plan, format, and implement a case. And of course, in all clinical exposure, there will be challenges, and we'll come to that. What do you think would be the challenges of a classroom management of early clinical exposure? If you were to do it tomorrow for 100 students, and now with MCI increasing our students, many of us have 200, 250 students or more, how would you be able to do early clinical exposure in a classroom?
Dr. Himangini Shah.
Yeah.
Himangini, please unmute yourself. Or Dr. Aarti Kinikar.
It's regarding the writing a clinical case, which can be used as a tool. So I could use a case scenario where a mother brings a child, where she finds that the child is passing a yellow colored urine and eyes are looking yellow. So when the physiology people are teaching, say, bilirubin metabolism or biochemistry, we could ask them why are the eyes yellow, or we could have like urine, especially for biochemistry, why is the color of the urine yellow, what is excreted, or talk to them about bilirubin metabolism. So that way, and then how will you do the tests in this child? Why is the liver enlarged in this child? So maybe the case will have to be written in that way. Child bringing with yellow coloration of the sclera, yellow colored urine being passed, and child is not feeling well and has a liver that is palpable. So maybe work on that and ask questions related to that. Is that what?
Yes,
Is
excellent. But what were the challenges that you would have in this? That's
Yeah,
where
the
the
challenge will be, I may give this case, and then there are 250 students sitting in front of me. So the ones who usually you will find that in a class there are same people trying to answer. So how do we get every to know each one has understood this? You might have only few people talking about it. So there are certain ways which in a classroom of 250, getting answers from all and then trying to fish it out. If we ask them to put it on paper, then we have to collect those papers, correct it. So the teacher's job is going to increase, so how individually to assess whether they have understood may be a bit difficult when you get, or like when you have on Kaun Banega Crorepati, you have them with some gadgets, A, B, C, D and all like that, so if those slowly those gadgets might come into the classrooms to make assessment easy. These are just thoughts, okay? The challenge will be how to know. Yeah.
Yes, anybody can think of other challenges. I'm sure you can think of the cases, but what would be the challenges and what would be the suggestions of how to overcome those?
Dr. Sumati, ME. Sumati, can you unmute yourself?
Yeah. Good evening, all. So actually, we have actually given framed few questions, and these practical examination, that is practical evaluation, also in our college we have done it on the cases, case based. So the question construction, the case construction will be like, no, we will be revealing the diagnosis. Students will not make any effort to diagnose the case. For example, in diabetic ketoacidosis, the symptoms and the diagnosis will be given more or less. It is more related to the biochemical aspect, like how exactly the mechanism of ketoacidosis happens and all those. But the challenges what we have faced so far is, so usually these case discussion, we have to take it on a smaller group. So there should be an elaborative discussion on each and every aspect of biochemical correlation with the clinical aspect. And if we discuss in the larger group, it may not be effective. And also, it should be like no more or less, it should be related to the real situations. Like no, artificially we can't add on more things which students get lost and they may not be able to get it. And these are the things we have got it validated from the clinicians. Look, when we started constructing these cases, we actually brainstormed and how it should be, which is real to the so these are the few challenges which we faced in the initial phase.
Excellent.
Yeah.
Anybody else would like to add some challenges that they have faced? So the common one.
On chat, people have written, we may need some helpers in the class. And
right.
Yes, then Sarla Devi, would you like to answer this? You have raised your hand. Dr. Sarla, she has lowered her hands. No more hands.
All right. So we really, what are the most important when we talk about early exposure in any of these settings? The important things that come, the first thing people talk about, we have such a short year. We are now already 1 year and we are spending so much time on a case. So it is loss of curricular time. I think that is the biggest challenge most teachers are facing. And I think there has to be a shift in attitude, because I think we have to stop thinking that we have to complete the syllabus. There is never going to be a complete the syllabus. We have to expose them to certain facts, and we have to, as Dr. Jamkar took for you all last time, talk about self-directed learning, and they will have to figure out some of it for themselves. And we may not be able to do everything, but we will teach them how to think and teach them some attitudes. And with this comes a lot of resentment from the faculty, that you're taking up my time. And that causes a lot of irritation. And an irritated teacher is not the best teacher in the classroom. So that's another thing. The third is territory issues. Anatomy, biochem, if you're trying to integrate that horizontally, anatomy, biochem, physiology, and have a case where you do all of that together, then these territory issues come. Who should do it, who's time, who should be leading it. So those are the other issues that come. And therefore, a good working relationship horizontally and vertically helps, especially like they just said that they got their cases validated. I think Dr. Sumati mentioned that they got their cases validated. And involving the clinician is very important, because it causes authentic cases to come into the picture. So getting clinicians to help you will be very important. And resources. You will need more people. You will have to learn how to break it into smaller groups, spend a little more time. So those are the challenges that really come when you're facing early clinical exposure. Suppose you were doing it in a hospital setting. You will have to think of utility of knowledge of basic sciences. You have to include wards, OPD, also the labs. Don't forget, you can take them to the labs. You can also talk of ethical situations and dilemmas that are there. Develop an observation guide. Who to observe, what to observe, for what purpose to observe. And of course, you cannot take 250 people in the class, from the class into the hospital. So whether you will do it by rotation, whether you will get a virtual patient, whether you will could take them to the primary health center in rotations. So everybody will have to do it depending on their resources and the things that they have available to them. Community. You have to think, what is it that you really want to learn? You don't want them to learn the same things that they're learning in the hospital, in the community. So exactly what kind of cases you want to see? What is it that they want them to realize? What is the context that you're trying to do? And major challenges is that where to take them in the community, how to take them, how to take the responsibility and the resources to take of that. And again, here, many people have a different thing. They've worked with public health department, community medicine department, and organize rural, when they have their rural placements, making the students go there. I know that people have now coordinated with community medicine, because most community medicine have their own vans, so that when their van goes, can our students come? So there are different ways people are integrating this with the help of them. So eventually, if you were to make an ECE module, this is how it would look. Beginning with your setting, for example, classroom. What is the topic or task chosen? That means what is your context? For me, it could have been, I'm going to talk about parietal lobe. Then what is my overall goal? The goal is that the students develop the knowledge of the structure and functions of the parietal lobe. What are the objectives? Student will be able to maybe describe the anatomy, the physiology, clinical features if there is a derangement or a problem with the lobe, and why there should be those kind of symptoms based on the anatomy and physiology if the parietal lobe is damaged, whether it is a dominant, non-dominant. And therefore, what we are looking at is in terms of expected competency is the student should be able to correlate the clinical manifestations with variations in the structure and functions of the lobe. And therefore, the learning experiences that the person should have, the teaching method we should use, maybe case scenario, bring a MRI, have a case discussion, If the case scenario is being planned, you should remember that you should give time for people to read the case and come prepared. Then it will be a richer discussion. Whenever you have teaching, you have assessment. So you will have to give feedback at the end of the discussion, how people participated, what they learned. Or you may have a theory and give them a case scenario and ask relevant questions. You will also after that think about how are you actually going to implement it. Whether you're going to develop the case scenario, who's going to do it, who's the core group, who are the people from the clinical side who will be there, when will it be implemented, how will the lectures and other things around it will be planned. They're using standardized patients, are you going to train them? What is the, eventually how will you evaluate the program? You'll get feedback from students, will you see the assessment scores, will you get feedback from faculty? So this is how, and eventually these are the parameters you have to look at when you're planning an ECE module. It is not just that I'll take them to the ward, it is not just let them go to the camp. Like any learning experience, it will have to cover many of these factors from planning, objectives, competency, implementation, and evaluation. Finally, for the last sign, so early clinical exposure can occur in all these three settings, and it can cause change and bring better demonstration of clinical problems, gain in knowledge, attitudes, training, ethics and professionalism, context, social relevance, and teamwork can improve. These are the references that I have used, and now we are open for questions.
Okay. Please ask questions, raise your hands or write in the chat box. Yes. So Dr. Pramod Goyal has asked, can the visualization of autopsy for first year MBBS students be taken as early clinical exposure, like observing brain hemorrhage or cardiomegaly? Dr. Pramod Goyal happens to be a forensic medicine specialist and quite often does autopsies in our college.
Yes, definitely it can be done. Only you may have to prepare both all the students for an autopsy and what to expect, and whenever you take them, what to observe and how to behave when an autopsy is going on. But it is a form of early clinical exposure. That's another way of doing it. Thank you for adding that.
Okay. Please raise your hands. Dr. Munira Hirkani, please unmute yourself. Dr. Munira, yes.
Hello. Yeah, Hinal, a very nice and interactive session. My question was about the proportion, like in the EC teaching hours, what should be the proportion ideally where the EC is conducted in a classroom setting, in the hospital setting, and in the community setting? I just want your views on this.
I think the most important thing, Munira, is to be flexible. There is no one size that fits all. I think it depends on your availability of resources. For a person, say, who's in Wardha, where they're working in the community, it is simpler to do community. If I was working in Mumbai, it is more difficult to do community. So while you may have ideals, you have to look at what are your resources. I think the best way to look at is what are you achieving with all of that, and if we don't have resources of, say, going to a community, is there an alternative way of imbibing those same attitudes in a different way, maybe going to a camp? I would not try to put it down as there is a fixed proportion for any of those.
No, the reason I put this question was like, we want an authentic patient encounter. The encounter is not the right word, but what we say, yeah. So in a classroom setting, just using cases or videos, we do not get that. So at least, I mean, the idea is like when you're having early clinical exposure, at least an attempt should be made to at least have some amount of actual patient contact.
No, of course. Now I know where you're coming from. I was trying to see whether you were trying to ask me what percentage it should be. No, the aim is to try and get some authentic. Like when I talked about early clinical experience in my first few slides, we talked about authentic. Okay, so the original context in which early clinical exposure came was authentic. That means you actually saw patients. But because of the challenges in always not being able to see real patients, came standardized patients, or came cases, or came virtual patients. Remember, nothing really beats the experience and the thrill for a person to interact with a real patient. So as far as possible, we should attempt to make some attempt to get at least some of these early clinical exposures as real authentic experiences. But again, it really is depends on the institute, because depends on what you have, many patients, how many students that you have. But the attempt has to be there to have at least one in each type, so that they have an exposure as to what it is. Definitely, point taken, Munira.
Thank you.
Dr. Rose Chakola, she says, need of 1 week prior preparation time for case-based class were relevant practical points. Thank you so much. How to observe, what to observe, and need of 1 week prior preparation time for case-based class were relevant practical points. Okay, she has made an observation. Then Dr. Artik Kinikar says that we assess impact of early clinical exposure after 1 year from the students and make necessary changes for 2020 batch.
Definitely, you know that program evaluation is a continuous process, and then we'll have to keep learning along the way.
Okay, Dr. Deepti, you want to say something?
Ma'am, I just want to ask, in a classroom setting, it should be a group discussion by the students regarding the case, right?
Right.
So now, traditionally, the seating arrangement is we have the tables in rows, and the students cannot face each other. So, do you suggest we change the way we arrange our seats in the lecture halls? Or it's okay for anatomy because we have dissection hall and we can teach in groups. But I'm just thinking about physiology and biochemistry, where it's not possible to have 250 students in one lab at a time. So if the lecture halls need to be changed, the way we like you put that video where the seating arrangement was not traditional, and they seem to enjoy learning much more when they were able to interact with each other. So I'm just wondering whether we should change the way we seat the students.
What a lovely point. But I'm wondering what other people have done, because I'm sure they have not been able to change furniture or change. I mean, if we could, we would have. But if we can't, I'm wondering what other participants feel. How have they overcome the challenges of the row sitting that we have in our traditional classroom? Maybe others can share their views and their experience, how they've overcome it.
Okay, Dr. Chetna Desai, she says, is it a good idea for students to shadow consultants as part of early clinical exposure, or is it too early for them?
So before I go to her question, I'll just answer the earlier question. Because while we can change the furniture of the place, that's not feasible. Honestly, it may not be feasible, because I know most people are scrambling to put in enough more rows so that they can meet the necessary extra students. So while it is not feasible, is there any creative way of them doing it? So I know that I have seen in our hospitals, we make them just turn around. Some of them sit on the desk, some of them sitting on the benches, and they're having discussions. We've had people group together in bits and pieces and do it. And at that age, they seem to be flexible enough to squeeze in and out and get into groups. So I guess creativity is the order of the day for allowing you to do that. And of course, if you have the capacity to change furniture, fantastic. You are the lucky one. Coming to Chetna's question, right, Chetna, is shadowing good? Well, what is the purpose of shadowing? Shadowing can be early clinical exposure, but what is it that they're observing? It is exactly if you have your objectives clear. What is it that you want? You want to learn, make them learn about how professionalism is, or if you want them to learn how a doctor talks to a patient. If your objectives are clear and your observation guides are clear, it can be used. But it is one-to-one and even more difficult to do. But definitely, thank you for that.
Dr. Arun, Dr. Avinash Supe.
Fine. Henal, very nice talk. Enjoyed it.
Thank you, sir.
Okay. Now the concept here, I think, is the question 2, 3, I think questions people have been asking. I understand, when we are creating guidelines, we have to understand there are going to be 700 colleges with different infrastructure. The word authentic is very important. In fact, when you talk about early clinical exposure, you want a patient. But the video and paper are alternatives. So I think it's a compromise, no doubt about that. But you can still have in a group, patient contacts. I think it is easily possible. You can bring a patient in a ward. I mean, that's in a classroom, you may require a lot of permissions, and I think patients have to be selected properly. But videos and paper are okay. The idea is you have to have a clinical context. That's all. I mean, if you understand the clinical context while teaching, we have achieved more than enough. I mean, following and all is okay. They are a part of ADCOM module. But early clinical exposure is making it contextual. That's all. I think that's the whole concept here. How do you do it? It's okay. I mean, people will adopt things. The books will come. I'm sure there are a lot of books coming on first year. So early clinical exposure also, people will come with cases and videos and all that kind of thing. But more important is people should use it.
True, very true, sir. And at least get the idea that the students get the relevance and the context. Thank you, sir.
Dr. Munira says, we have planned to take EC in classroom setting in small groups in labs and demonstration rooms. Then
okay.
Dr. Satendra Singh says, very succinct interactive talk. This is how we should give webinar. Thank you, Dr. Shah. Okay. Dr. Arun Jamkar.
Good evening, sir.
Dr. Arun, sir. Sir, you are unmuted. I think there is some problem with the speaker here. The microphone has got some problems, maybe. Okay, then there is Dr. Dr. Sarla Devi. No. It was an old hand. So I think, yes, Dr. Sarla Devi has written, ma'am, MCI recommends 30 hours for ECE. How to go about it? A very, very relevant question.
So may I, before I answer that, can I ask others who are already doing and planning to give their ideas so that becomes a forum for people to exchange ideas instead of my answering that? And then maybe I can add something. So if anybody else wants to share how they're doing it, how are they accomplishing that 30 hours? Because I know many people have made their curriculums and planned out the 30 hours. So if people want to share that.
I mean, this 30 hours issue is very, very reason for a lot of discussions in many medical colleges. The issue of 30 hours. So
is it 30 hours or 75 hours?
So whatever the hours are, but we are all.
No, I think Munira, you just tell me exactly how many hours are there.
Hello.
Yes.
Yeah, hello. Yeah, it is 90 hours. 90 hours early clinical exposure. So what we have done is we have divided 30 hours between each of the preclinical subjects to take the responsibility and the lead in that early clinical exposure session.
And Munira, if you can go ahead and tell them whether you're planning to get patients, what are the things that you have.
How are you planning your 30 hours of physiology?
So what we have done is we have roughly, including the vacations, etc. I mean, excluding the vacations, we have 10 months of teaching, if you can say, excluding the exams. So every month we have one early clinical exposure session that we have planned. Some of the sessions which we are planned in the hospital or OPD settings, we have done it during the practical rotation. So students go in small batches. So it becomes feasible, though, and you can say majority of the sessions when we do have it in the classroom setting with paper-based cases, videos, but they are all in small groups. We have not planned it in the lecture, what we say, large groups, because it is difficult for discussion with 250 students.
And are you using, would you be using the labs and other areas around your classroom?
Yes. Yes. So for early clinical exposure, we have also included lab visits. Yes. Like one is to the blood bank. So we have it along with the hematology sections. So that's one thing we have done. The other thing is like simple things on history taking, etc., which are essential competencies to be demonstrated. So we have we are taking them to the GOPD to, I mean, that's the plan, to have them take histories, etc., of patients who are there, simple with the proformas. So that is one thing we wanted. And then we, of course, we are planning debriefing sessions after each of these ECE sessions, so that we can add on to it, take the students' experiences about it, and see whether the objectives have been covered or not.
So, as Munira has explained, you know, Dr. Sarla Devi, that when you have to finish the 30 hours for your subject, I understand why you're 30 hours, because she's talking about 30 hours in her subject she'll have to finish. You'll have to think of how to integrate early clinical exposure with the topic that you're doing. So maybe if that 30 hours is, you know, you're just spending a little bit more time if you were doing anatomy of the hand, and then you were, you know, you have to do, I think you're an anatomist, right? So if you're doing anatomy of
yes,
how you would get that into the picture, or if you were doing a lobe, you would get an MRI in the picture. So, you know, it is just being a little more creative. Yes, a lot more hard work, because with every lecture will come how to plan it, how to implement it, how to assess it, and eventually how to evaluate it.
Yes, ma'am. That's what we plan in our institution. 3 hours in a month, ma'am. 3 hours, continuous 3 hours in a month. Taking about a topic, and we are planning to take them to the clinical side to show the patient the topic. That is what we plan.
I guess you'll have to take them in smaller batches, because if you're going to the hospital, you can't take.
Okay, ma'am. Okay, thank you.
Thank you very much.
In fact, there are I sometimes see that there is overlapping of different subjects in these clinical hours, this early clinical. I mean, you have some part of anatomy, some part of physiology, and if you go to the lab, there's some biochemistry. So it's all sometimes becomes a little bit making segments of it. It's a bit difficult.
Dr. Bedi, integrating responsibility. It's not necessary. I'm sure they're horizontally integrating, but who takes the lead depends on that.
Okay.
That becomes integrated, no, ma'am? That becomes integrated lectures.
Yes.
Dr. Rituparna Barua from Assam. Can you unmute yourself? Okay. On chat, how to, she has written on chat, how do you train the residents to take the session?
I'm not sure what you really mean by residents to take the sessions. They will be the people who are being exposed, but you will have to either take them there or you will have to give them an observation guide. I'm not really understanding that question clearly. We can have peer learning if that's what you mean. I'm not sure if that's the question.
Dr. Tanya Agarwal. Can you unmute yourself? Dr. Tanya? Dr. Tanya, you are self-muted. Please unmute yourself. Or you can write. Dr. Anil Kapoor says on chat, I think it will be nice to develop some paper cases and case scenarios. Videos identify the objectives for each case. Since it will be an intensive exercise, we can make a few groups, maybe on MEU India Google group, who can work together and design the whole EC modules, which can be used by at all medical colleges.
Excellent suggestion. Just like we have MCQ banks, we probably will have case banks which can be used for early clinical exposure. Anil, maybe Dr. Anil can take the lead in that.
Yeah. I'll, whatever help I can give, I'll be happy. Yes, Dr. Tanya, you are unmuted now. Please speak. Oh, we can't hear you. You can write on the chat box. Okay, Dr. Aarti Kanitkar. Dr. Aarti, please unmute now. Yes.
Yeah, now it's possible. It's just one of the ways in which we have written our timetable is like because of the horizontal integration, maybe one topic is taught in anat, physio, and biochemistry, and the following week the students will be divided into small batches of 20 and they will be going by rotation to medicine, surgery, gynec lab, the CCL lab, and they will take after this period of in the afternoons. So that way the biochemistry, they see the clinical exposure of the same topic. Say if it is head neck face taken to this wards over the next 1 week, and then again they have another topic in that subject, again they can go. So you can break it and do it rather than doing it at a stretch. So that is what we are planning.
Excellent. So you found a solution in your context, how to break it into groups and rotate and let them go. So that will be very effective. Excellent.
Yeah, because we can't do it after a gap of 1 month or so. So maybe that early clinical exposure is broken down over a period of 3 months, 4 months, but after a talk.
Yes. You always have to think how you're going to integrate your early clinical exposure with the rest of your curricular elements, whether it is your, whether it is your lectures or your visits or your exams. So you always have to think about how to integrate all the different elements.
So, Anil Kapoor says, sure, ma'am, we can give it a try and work out 3 cases to begin with, 1 each for anatomy, physio, and biochemistry. Dr. Tania says, we are planning 1 session each of 3 hours each month. In that session, full faculty of department will be taking care of a batch of 150 students.
So it seems that every hospital or every institute has figured out their setting, how they are going to do it. And everybody's setting is different and everybody's approach is different.
Sure.
Like Dr.
Henal,
Yes, sir.
Sanjay, can I say something?
Sure, sir.
See, yesterday I was talking to the special officer of that board of governors in MCI, and that board of governors and all, they're planning to start a portal now. Whether they call it as the MCI portal or NMC portal or whatever it is, there's something like a repository. So I have suggested your name, and I've told them that we need to now have all ideas, resources, what people are making, all these kind of resources, whether it's a PowerPoint or cases, videos, as well as plans, I think we put it onto this repository with consent of people. And if it has to be shared, I think it can be shared with across colleges. People can pick up programs which suits to them within the framework, and they can really work on this, because I think we need to develop newer resources in this area, because there is so much of variability. Some people can do it for 50 students, some people do for 250. So I think this repository will be something like, will create like a publication. It's not just putting it like that, but made it publish or made it portal. There'll be a consent, there'll be a credit which will be given to people, and there'll be proper kind of an quotation or citation will be there. So I think we need to work on these. So this will be a future, that this year's experiences, people will go on refining their materials, and we will create a lot of material over a period of time.
So that's an excellent idea, because they'll get a scholarship, so that will make them want to share it. And also people will benefit, because, it is very difficult for every institute to do everything.
Sure. So we don't want to cut down anybody's scholarship. We want to give them credit. At the same time, we want that it is spread out across and people share. There's a lot of peer kind of a sharing which occurs, and ultimately beneficiary will be students according.
Yes. Dr. Rajeshwari says, how to conduct 12 hours of hospital visit in physiology department. What about the observation guide?
So I think in my references I've put about observation guides, and even I think in the things I've said, what should the observation guides do? I think you have to work with a clinician and decide what the observation guides do. Because that will tell you what will be the focus, target, and I think there are references which I have put that can be used for observation guides.
Yes, sir.
Hello?
Yes.
Hello, can I say something, Dr. Beti? Dr.
Yes,
Himangini?
yes, please.
An interesting aspect what we also were looking into is a self-directed kind of early clinical exposure, wherein we ask the students over a weekend to sort of visit a place nearby to their residence, wherein it could be like an orphanage or a old age home, and have an interaction with the people at the inmates, and check out what could be their problems, what could be their issues, and we give them a template which they fill and they come back next time. And then in the classroom, this gets discussed. So we're just thinking about something like that also. Well, certain permissions are required, but then if they are sort of aware of their surroundings, of such places, and they have a good rapport, maybe they can get permissions, it would be interesting. Of course, it would be varied for different people, but then it would be like, some interesting inputs could be there. The other thing that we were thinking of is community walks. When they're taken to the primary health center and the urban health center, we divide them into groups, and then one group goes down along the community, and then we visit an Anganwadi and have a discussion there, or our immunization clinic where we have the immunization card as a resource, nutritional growth chart as a resource when we are talking about that, and we try and correlate that with biochemistry also at times. So we're just brainstorming.
I am sure, as Dr. Supe said, that everybody is going to try different methods, and we will and refine on them. And I guess 1 year later, we'll be sharing our experiences and learning from each other. Thanks, Hemangini, for sharing all plans.
Can you please put the reference slide on again? Thanks. Especially the guide that you were referring to was interesting. Thank you for the. Thank you, Enel. Thank you very much.
Thank you.
So I don't think we have any more hands. Dr. Arun sir, Dr. Jamkar sir, would you like to make a comment? I think no, we can't. No. Yes.
Yes.
No more questions.
No more questions.
So thank you. Thank you. That was a very.
Thank you, Enel.
Thank you, Enel.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Supe sir.
Thank you, Dr. Supe sir.
And thank you, friends.
And thank you, friends.
So, Henal, can we end?
Yes, thank you. Thank you, Dr. Bedi.
Yeah, some echo going on. So.
Yes. Thank you and good night, everyone.